Hi everyone, good evening. This is the detail of the slide that I shared with you today afternoon. This is an interesting case of bladder schistosomiasis, and this is Schistosomia hematobium. And I will just tell you why it is hematobium and not Mancini. And I will look through the same video that I had sent you, a whole slide image of the same. So now let's examine the histopathological feature of bladder schistosomiasis. Largely it is as a result of the host immune response of the eggs that are trapped within the bladder that you see this histological picture. The hallmark of the disease is presence of the Schistosomia hematobium eggs, which are oval with a terminal spine. So I'll just pause here. So if you're able to see, even in this image, you're able to see there is a terminal spine, right? Any of these images, when you see there's a terminal spine, I will just forward it little more. Yeah, so here also you're able to see very clearly that there is a terminal spine in any of these eggs. So wherever you're seeing, you're able to see a terminal spine. Let's look at a few more images. So see, here also there is a terminal spine. So it again, they can be tangential cuts, but you will be able to clearly see a terminal spine in all of these cases of Schistosoma hematobium, and also the location also. Bladder is most commonly affected by Schistosoma hematobium, while the Mancini affects the stool and it resides in the mesenteric plexus. So the eggs are usually viable, and they contain the miracidium, or they may degenerate and can become heavily calcified. When you're looking at the histological images, there can be much of a change. So in an early active disease like the one that I have shown you, the bladder mucosa will show some marked edema and congestion and a dense eosinophilic infiltrate, like the case that I have shared with you. There can be a mixture of chronic inflammatory cells also here and there. You can have lymphocytes also and some plasma cells also. Microabscess formation is generally seen when the eggs become entrapped in the bladder. That is when you find a microabscess kind of a picture. You can have a foreign body granulomatous reaction also. Sometimes the granuloma is predominant, especially in chronic cases. You may not have much of an eosinophilia, but the granulomas can be chronic granulomatous disease kind of a picture also. They are composed, as you know, of epithelioid histiocytes, numerous eosinophils, foreign body and type of giant cells, lymphocytes, plasma cells, and they can be surrounding fibroblasts also if it is very much long standing. In chronic disease, there can be additional features that the fibrosis can be very, very severe in the bladder wall. So there can be dystrophic calcification of the dead eggs, and there can be thickening of the bladder wall. There can be prominent mucosal ulceration. There can be some polypoidal inflammatory reaction also. And in long-term cases, this can predispose to some amount of development of dysplasia and finally can result in a squamous cell carcinoma also in a very, very long-term case. So it can be the type of an invasive keratinizing squamous cell carcinoma by the time you see it in a long-term case. Grossly, when you see, the bladder might have sandy patches, and your histopathology checklist for diagnosing in Schistosoma hematobium is terminal spine in Schistosoma X, eosinophil-rich granulomatous inflammation, foreign body type of giant cells, fibrosis and calcification, squamous metaplasia or dysplasia in long-term cases. So every bladder biopsy showing granulomatous cystitis with prominent eosinophils, especially in a patient from an endemic area like that of Africa, in those areas you have to be very careful that you have to look for these eggs, and you cannot just call it an eosinophilic granulomatous reaction. You might be missing these eggs in endemic areas. If you see in the Indian perspective, basically, if you see the Indian perspective, there are areas in India which are not exactly considered endemic, but still there are where they were noticed were Maharashtra and Tirupuran which is an area in Madurai in Tamil Nadu. So these are the areas where they were actually found. But the infection rates have come down very predominantly these days, and we no longer find these schistosomia cases that often. So let's discuss the two important species that cause schistosomiasis, which is Schistosoma hematobium versus Schistosoma mancini. If you're able to see, the egg architecture itself is different. The Schistosoma hematobium is a little more longer than the Schistosoma mancini. It's clearly an oval kind of a structure with a terminal spine, usually found in the urinary tract, while Schistosoma mancini is a little more stubby and the spine is lateral. And this is usually found in your stool sample. Okay, so that is one major difference. Schistosomiasis is a chronic parasitic disease that is caused by blood flukes that belong to genus Schistosomia. So this affects nearly about 200 million people worldwide, and the rates have come down. Mainly it is found in Middle East and Africa and less in Indian subcontinent. So unlike the other trematodes, the Schistosoma species have separate male and female worms. So it is the eggs and not the adult worms that cause the tissue damage. It is always the eggs that is causing the tissue damage because of the presence of that spine. So both species have the same life cycle. The eggs are passed into fresh water and the schistosoma pass through urine and Mancini through the stool. The eggs hatch to form miracidia larvae, and these miracidia infect freshwater snails. So these freshwater snails develop the cercaria within them. The cercaria is the infective stage to the humans, and the next human being, when he comes in contact via skin, these cercaria larvae penetrate through the skin, and during this happens during contact with this contaminated water, whether it is because of bathing or washing clothes, or when they come in contact with dirty water. So that is the reason that it gets cercaria again infects the human being. So Schistosoma hematobium basically loves to reside in the vesicular venous plexus, that is around the urinary bladder. Therefore, the eggs are found in the urine. And the characteristic egg, as I told you, has a terminal spine. Clinically, it presents as some hematuria, dysuria, recurrent UTIs, and chronic infection can lead to bladder fibrosis. So there can be patches when you look at the bladder specimen. And histologically, there will be eosinophilic granulomas, foreign body giant cells, fibrosis, calcified eggs, or in a very late stage, it can result in squamous cell carcinoma also. Schistosoma mancini, on the other hand, is something that loves to reside in the inferior mesenteric veins. It does not reside anywhere close to the bladder. So its eggs are primarily passed in stool. Of course, there's nothing like an all or none phenomenon, because it can infect both places, but predominant is what I'm talking about. So it causes Mancini causes an intestinal schistosomiasis. So the patient usually presents, unlike Schistosoma hematobium, where the patient will present with dysuria, this guy will present to you with abdominal pain, chronic diarrhea, stool having blood spots, and the eggs might get trapped in the liver also to produce granulomatous inflammation in the liver also. So they are also prominent in producing periportal fibrosis in the liver, and the patient can have, in very chronic cases, can have portal hypertension as well, with hepatosplenomegaly and esophageal varices. So when you're seeing hepatosplenomegaly, esophageal varices, and some amount of skin lesions, so look for Mancini in those cases as well. So basically, both the pathologies are rich eosinophilic granulomatous disease, but the area that it affects is different, and there is a predisposition for fibrosis and permanent tissue damage in both the cases. All right. So the diagnosis primarily is made when you look at the egg itself. Another very important thing is, whenever you are collecting a urine sample, all the pathologists have a habit of telling them that we need the early morning sample. But for schistosoma, when you're suspecting a schistosoma case, always remember that you have to collect a midday urine specimen and not the early morning specimen. And in stool also, you can look for the Mancini eggs. And biopsy will show you the characteristic kind of a picture. If you see the Indian perspective, although India is not considered endemic, the reason is not because of freshness in the water. The reason is because the freshwater snail is not something that endemically resides in India. So that is an intermediate host which is very much necessary for the life cycle of schistosoma, and we lack those species in India. So that's the reason why schistosoma is not so common in India. So always remember one take-home message from me today. So terminal spine, Schistosoma hematobium. Lateral spine, Schistosoma mancini. So terminal spine, Schistosoma hematobium affects urine. It is a bladder infection, and then it can lead to squamous cell carcinoma. Schistosoma mancini, you will find it in the stool sample. It causes liver and intestinal infection, and it can lead to portal hypertension. Okay. So that is one important thing. And this is a table that I have made for you guys. I'll be sharing it in this group today. So this is Dr. Deepa signing off today. Bye-bye.